Hello, my name is Rebecca Altman, and welcome to my presentation titled Pelvic Health Physical Therapy for Underactive Pelvic Floor Conditions. Here are the topics I will be covering in this presentation. The pelvic floor has many roles in the body. It controls closure of the sphincters around the urethra and anus. It also functions like a sling to support the pelvic organs, especially the uterus in female-bodied patients, the bladder, and bowels. The pelvic floor works in tandem with the diaphragm to allow inspiration and expiration, as well as controlling intra-abdominal pressure. Lastly, it allows for sexual arousal and orgasm. The pelvic floor can be divided into three major layers. The superficial layer contains the bulbocavernosus, ischiocavernosus, and superficial transverse perineal muscle. These structures help achieve and maintain erectile tissues. In the perineal membrane, the striated urogenital sphincter complex allows involuntary and voluntary closure of the urethra to maintain continence. The pelvic diaphragm contains the levator ani muscle group and the coccygeus muscle, which are necessary for breathing and pelvic organ support. Looking at the pelvic diaphragm in more detail, the levator ani is composed of three individual muscles that work together. These muscles are the iliococcygeus, pubococcygeus, and puborectalis. Although the fibers of these muscles cannot be distinguished during an internal exam, the different directions contribute to the three-dimensional movement of the levator ani. Also visible on this picture are the coccygeus muscle and obturator internus. It is important to note that the pelvic floor is made up of about 70% slow-twitch fibers and 30% fast-twitch fibers. The slow-twitch fibers allow the pelvic floor to be in a state of constant resting tone and support pelvic structures as well as the spine. The fast-twitch fibers allow for quick closure of the sphincter around the urethra to prevent leakage of urine during instances of high intra-abdominal pressure, such as when laughing or coughing. The pelvic floor is innervated by the pudendal nerve, which originates from the sacrospinal nerve roots S2 through S4. It is responsible for sensory innervation of the external genitalia and perineal skin, as well as providing motor innervation to the pelvic diaphragm. The pudendal artery is the main blood supply to the pelvic floor and is important for sexual arousal. The two most common pathology associated with a weak or underactive pelvic floor are pelvic organ prolapse or POP and urinary incontinence. According to the International Continence Society, POP is defined as the descent of one or more of the anterior vaginal wall, the posterior vaginal wall, the uterus, or the apex of the vagina, and urinary incontinence is simply observation of involuntary loss of urine. The main symptoms of POP are pressure or a feeling of heaviness in the vagina, pain in the pelvis or low back, and urinary, sexual, or bowel dysfunction. There is also the potential for psychological symptoms such as negative body image and decreased activity due to symptom severity. It is worth noting that the severity of symptoms is not correlated with the severity of prolapse. The graphic on the left shows many of the risk factors associated with developing POP. A combination of these factors may lead to a greater chance of developing a prolapse. White women in the United States have the highest percentage of diagnosis at 12% of the population, followed by Hispanic women at around 7%, and so on. Depending on the source, the prevalence of pelvic organ prolapse varies widely, with no consensus on how often it occurs in the population. There are also many affected people who do not seek medical care for this condition due to lack of health literacy, embarrassment, or social stigma. There are three main types of urinary incontinence: stress, urge, and mixed. With stress incontinence, a rise in intra-abdominal pressure causes a failure of the sphincter to close properly, leading to leakage of urine. Urge incontinence is preceded by a sudden and intense urge to void and subsequent leakage. Lastly, both symptoms can occur simultaneously. There are many risk factors for urinary incontinence, the biggest being gravity, number of pregnancy, and parity, number of births. High BMI, age, mobility impairment, previous hysterectomy, and cognitive impairment also place patients at risk. It is estimated that about 8% of the global population, or about 421 million people around the globe, experience some type of urinary incontinence. It is important to assess the onset, symptoms, frequency, and duration of the patient's chief complaint during an initial subjective interview, whether the patient is experiencing symptoms of a prolapse or urinary incontinence. The location and quality of pain, infection history, and presence of other medical conditions may guide your exam and differentially diagnose a pelvic floor dysfunction from other causes. It is important to note that if a patient has impaired cognition, it is unethical to perform an internal examination as the patient cannot provide consent. Some medications can cause increased urge as a side effect, so it is important to review them with your patient. It can be beneficial to review diagnostic imaging, such as a urodynamic study if your patient has had this done. Red flags should be used to screen out cancer risk. Complete loss of bowel or bladder control may indicate caudate equina syndrome, which should be treated immediately. Pelvic floor muscle contraction is tested using the perfect scale, with the patient in hook-lying position and with the therapist facing the patient. The therapist inserts a gloved and lubricated digit into the patient's vaginal introitus and first assesses the patient's ability to contract the pelvic floor. Grades for power are given using the Oxford grading scale developed by Laycock and shown on the right side of the screen. To test endurance, the patient holds a pelvic floor muscle contraction for up to 10 seconds. Then the patient is asked to maximally contract their pelvic floor, holding for the same amount of time as measured in the endurance test for up to 10 repetitions. The ability to quickly contract is assessed by the number of 1-second contractions performed in 10 seconds. Elevation is marked as either present or absent. Co-contraction is present if a contraction of the transversus abdominis is felt during a voluntary contraction of the pelvic floor. Lastly, to assess timing, the patient is asked to cough, and an involuntary contraction of the pelvic floor is either present or absent. Pelvic organ prolapse is typically graded by an OBGYN or urogynecologist. However, perineal descent testing and prolapse testing may be performed by a PT. These tests involve a maximum Valsalva effort or bearing down by the patient to observe bulging in the vaginal introitus. Urinary incontinence may be diagnosed by a PT by using a bladder diary. This involves having the patient track their intake of fluids, number of voids per day, and episodes of incontinence. It is recommended that adults intake about half an ounce or 15 milliliters per pound of body weight throughout the day. The typical adult should void between 5 to 8 times per day with about 2 to 5 hours between voids, and at most once during sleeping hours. Episodes of incontinence can be measured by pad use or by estimating the amount of leakage. Pelvic floor muscle training is indicated for patients experiencing urinary incontinence, urgency and/or frequency, bowel symptoms, and pelvic organ prolapse. The pelvic floor physical therapist can use the patient's results from the perfect scale to determine the impairments of the patient. For example, a patient with 2 out of 5 muscle strength, 3-second endurance, and absent co-contraction can follow the program outlined on this slide. Placing the patient in a gravity-assisted position, such as placing the legs on a wedge, can help the patient with a weak pelvic floor successfully contract their muscles. It is also recommended that patients practice pelvic floor contraction in gravity-dependent positions, such as standing, squatting, and even jumping to increase the salience of the exercise. Vaginal cones, or weights, as pictured to the right, can also be used to increase exercise intensity. There are several uses for electrical stimulation and biofeedback in conjunction with pelvic floor muscle training. Neuromuscular electrical stimulation, NMES, is typically delivered via intravaginal electrode. High-frequency NMES is used to improve pelvic floor muscle strength and coordination, while low-frequency NMES is used to normalize detrusor activity. The desired effects of high-frequency NMES are excitation of the sensory fibers of the pudendal and pelvic nerves, reduction in stress urinary incontinence, and reduction in the severity of pelvic organ prolapse symptoms. Low-frequency NMES has been theorized to reduce symptoms of urge urinary incontinence and increase bladder capacity. Electrical stimulation can also be delivered via transcutaneous electrical nerve stimulation, or TENS. Placing the electrodes on the sacrum, on the sacral plexus, or on the posterior tibial nerve has been demonstrated to decrease urinary symptoms in patients. The mechanism of action for both NMES and TENS is still unknown, and more research is needed to determine its effectiveness. Biofeedback uses surface EMG to measure muscle contraction. The electrodes are placed on the perineum, and the patient is asked to perform pelvic floor muscle contractions in varying positions and watch the electrical activity increase on a monitor. Biofeedback can also be used to downtrain the pelvic floor by encouraging the patients to relax completely until a baseline of activity is measured. For the treatment of urinary incontinence, especially urge and mixed types, behavioral modification should be considered as a first-line treatment. Identifying triggers by analyzing a bladder diary can help the patient to determine when their episodes of incontinence are more likely to happen. Once the patient has identified their triggers, the PT can educate the patient about urge suppression techniques to decrease episodes of incontinence. The patient should be instructed when they feel the urge to take deep breaths, perform some pelvic floor contractions, and then calmly walk to the restroom. Patients should consider eliminating bladder irritants such as coffee, alcohol, and carbonated beverages, and increase water intake, as concentrated urine can also irritate the bladder. Patients who experience nocturia or frequent urination at night can benefit from decreasing their fluid intake about 2 to 3 hours before bed. Lastly, avoiding bearing down or straining while urinating and defecating can help patients with prolapse avoid symptom exacerbation. Thank you for listening to my presentation. Please feel free to reach out to me via email.